Hello, and thanks for tuning in. In the last episode, I went through a 10-minute detail on why Medicare for All is not something we can do, why we can't afford it, and why it would probably crush the economy. If you didn't see that episode, let me give you the highlights. We can't afford it, ever. It just is not possible. To put it in perspective, we spend more money on health care than the entire economy for all but 4 nations in the world, and we're one of the 4. So there's only 3 other countries that spend more money in their entire economy than we spend on healthcare. That's how big it is. Our healthcare economy in this country is the combined GDP of Spain and Russia put together. Okay? The idea that we could just raise taxes to pay for Medicare for all is ludicrous. It can't happen. So that's easy enough to do. It's easy enough to throw stones at somebody else's idea. The hard part is come up with your own idea. So over the next 10 episodes, I'm going to come up with 10 things that I think we should do that could fix our problem with healthcare in this country. Now, first of all, let me start out with, there's no magic bullet here. There's no single bad guy. It's not just the insurance companies. It's not big pharma. It's not doctors making too much money. No, it isn't. It's a lot of things, and it's going to take a lot of things to fix it. Some pretty hard things. Today, we're going to start talking about rationing. Now, before you go running for your safe space and trying to cry with your towel, we're going to have to deal with some hard issues. Rationing is one of them. Rationing in and of itself isn't a bad thing. Purely and simply, the economic definition of rationing is the distribution or allocation of a limited commodity. And boys and girls, ladies and gentlemen, money is a limited commodity. We don't have an endless supply of it. So we're going to have to talk about rationing. And rationing can be done well if it's efficient and fair and produces the best outcome. So the first item I'm going to talk to you about is rationing in the order of trying to figure out who we cover, what we cover, and when we cover it. Right now in this country, the services, the drugs, the procedures, the testing you get is highly dependent on who your insurance carrier is or whether you're covered by Medicare, Medicaid, or your employer. That shouldn't be the case. Good clinical medicine should be good clinical medicine. If something has efficacy to it and is cost effective, it should be provided for everybody, not for some people with one health insurance and not for other people with another. So what I want to talk about is the idea of a national coverage policy, a national sets of policies that start to dictate what we cover and when. This will do a couple of things. 1, it will be fair for everybody. 2, it'll eliminate unnecessary prior authorization. And 3, it'll start to inject some market forces into the economy and into healthcare that will help drive down costs. Okay, so here's my idea. Already there is this committee in Washington called the Rut Committee. Don't have to understand what it's for or why it's there, but let's just use it as an example. The Rut Committee has 31 seats on it. 21 of those seats are physicians, one from pretty much every medical specialty out there. So there's somebody from the American College of Cardiology, neurology, radiology, etc. The other 10 are lay people. This committee could be used to start to decide and develop coverage policies, what's going to be paid for, and when it's going to be paid for. They should also include economic factors in their decision making. Right now, those really aren't included. So if somebody makes a better drug and it's better clinically, but it's 10 times more expensive, it could get covered. A couple of years ago, I was speaking to a group of oncologists, and I was talking to them about this concept of using economic factors, and they were a little bewildered. And I said, all right, let's put it this way. If a new drug came out that increased life expectancy for a certain cancer, and it was only $10 more than the old drug, would you all prescribe it? And they said, absolutely. $10 for 6 months? That's easy. I said, all right, what if it was $1 million more, and it only bought another 6 months of life? Would you prescribe it? And then their looks got a little uncomfortable. Most of them said, well, probably not. I said, okay, we've now established that life does have a value, that there is a limited amount of money that we should spend on 6 months of additional life. I know it's a hard concept to deal with. So what we now need to find out is, where is that line? What is the number? The Rut Committee could help do that by including economic factors in what we would cover and when we would cover. This would add market forces in a place where they don't currently exist. Right now, again, drug companies can make a better drug and know it's going to get covered purely if it's only better, and it only marginally better. But what if they also had to do what everybody else has to do in the economy and say, Well, it's also cheaper, or it's almost as good but a lot cheaper. We would have to have an appeal process to this because medicine isn't all cookbook. There would have to be a process for a physician to go somewhere and say, look, I understand that normally we would cover A, but this patient has the following idiosyncrasies or different clinical presentation. I need an appeal. Granted. So it wouldn't apply 100% of the time, but it would apply most of the time. This would eliminate this prior auth process, a process the physicians hate, where they've got to do a different prior authorization or the mother may I to an insurance company to get something covered. And oftentimes, it's a different process for every insurance company with different outcomes given the same clinical presentation. That would all go away. Think about what that would do for a minute. In a recent AMA study, 91% of doctors said that prior authorization processes have a negative impact on clinical outcomes. Okay, they didn't say that it made them angry and it cost them time and money, which it does. They said it had a negative impact on clinical outcomes, and we're spending a lot of money to do it. Recent reports show that prior authorization costs physicians around $30 billion a year. $30 billion of money that's being spent on something that's not clinical. As a matter of fact, has a negative clinical outcome. Now, if you assume that on the health plan side there's an equal amount of money, because every time a physician submits a prior auth, somebody on the other side has to review it, we're talking about wasting $60 billion a year. Okay, that would all go away in this idea of a national coverage policy. It would also create market incentives to produce more cost-effective products and services. All right, let's take the pharmacy industry, but this would happen across the board. Right now we spend about $330 billion a year on medications, on pharma, and it's going up at a rapid pace. If we could reduce that spend by only 10%, we'd save $33 billion. Okay, so I got $60 billion in prior auth, conservatively $33 billion in drug cost savings. That's $93 billion. Guess what? That's how much Medicare paid in total to physicians last year. We did one simple thing and we saved enough money to cover the entire Medicare budget for doctors. All right, here's how it would work and how it would create those incentives. Right now, if you're unfortunate enough to have a diagnosis of MS, there are a number of wonderful drugs available that will help you deal with your condition. Tysabri, Orencia, Lemtrada, Ocrevus. Okay, they're all very expensive. And when the next new drug comes out, it'll be more expensive, and it might be only marginally better, and it will be used. But let's say that this group, this Rut Committee, started to decide what the frontline drug was and what it was going to be. And that was what was going to be covered. That drug manufacturer would know that they would garner the market share. So another drug company out there is working on a drug, and let's say it's just as effective as this other drug. But it only works for about 95% of the patients. There's 5% of the patients that would need something else. And they bring it to market, and they bring it to market at a price lower than the drug it's going to replace. Well, then the Rut Committee would approve that drug, and they would suddenly get a huge market. Now, the company that produces the drug that got replaced has an incentive to lower their price. And if they lower their price, then they're going to garner the market. And now we have competition to what is the most cost-effective drug, not just the most clinically effective. That can produce enormous savings. And it's how the rest of the marketplace works. If you can produce a better product from a quality perspective at a lower cost, you sell a lot of that product. So conservatively, we've come up with $100 billion just by dealing with drug cost and prior auth. And there's a whole lot more money there. Now, $100 billion on a $3 trillion spend doesn't get us all the way there, but like they say in Washington, $100 billion here, $100 billion there, eventually you got real money. We're off to a good start, but it's only a start. So stay tuned for the next 9 weeks, and I'm going to walk through 9 more things that I think will get us to the finish line. Thank you.